Good evening, everyone.
Good evening.
Good evening, everyone.
Good evening.
It's 18:01 my time, so we're just going to wait for about 2 more minutes so that other people can log in and we begin.
Hi, this is Ruth. I'm in. Hi, everyone.
Hello.
Good evening, everyone. It is nice to have you around as we have this meeting. First of all, I would like to welcome you all to this patient-led World Sickle Cell Day webinar organized by the Sickle in Africa Consortium and 8 sickle cell patient support groups across Africa. We thank all the Sickle in Africa Data Coordinating Center SADC for organizing and providing logistical support. Sickle in Africa is a research consortium that has set up an African sickle cell disease registry and aims to enroll about 30,000 persons with sickle cell disease into a registry. Sickle in Africa is currently operating in Ghana, Mali, Nigeria, Tanzania, Uganda, Zambia, and Zimbabwe. The Clinical Coordinating Center is in Tanzania, and the Data Coordinating Center, SADC, is at the University of Cape Town in South Africa. Sickle in Africa is funded by the NIH, National Heart, Lung, and Blood Institute. The theme for today's webinar is sexual and reproductive health considerations for persons living with sickle cell disease. We have 6 speakers representing clinicians, researchers, and persons living with sickle cell disease. The last 30 minutes of this webinar is dedicated to questions and answers about anything in relation to sexual and reproductive health, even if it was not highlighted by the speakers. So please start posting your questions and those of your family members and friends in the question and answer box. The first speaker is Dr. Deogracias Manube. Now, Dr. Deogracias Manube is a consultant pediatrician at Mulango Hospital in Uganda. He is also an honorary lecturer in the Department of Pediatrics and Child Health, Makerere University. Dr. Manube, who has been working at Mulago Sickle Cell Clinic for 20 years and has substantial experience in managing stroke in persons living with sickle cell disease. He's an investigator at the SickleInAfrica site in Uganda. Today, Dr. Manube will give us an overview of the sexual and reproductive health, and you're all welcome to paste your questions in the chat box as the presentations are going on. Welcome, Dr. Manube.
Good morning, good evening, and good afternoon to everyone. I hope you can hear me clearly.
Yes.
Molly? Okay, great. So I'm just going to share my video for a short while just to make sure that I'm not a machine or an AI, and then I'll turn it off, and then I'll go straight to my slides. All right, great. I hope the slideshow is on, and I think we can begin. I have been introduced, so I will not go through that. That will be the order of my presentation. So going straight to the definitions, and I know this will be repeated over and over to make sure that each one of us are together. This is just a definition by the WHO, which basically reiterates the health concept. But in this case, it now adds on to the aspect of matters related to reproductive system, to its functions and its processes. And what is important with this definition is that it highlights the reproductive health aspects in people. One, the ability for someone to have a satisfying and safe sex life. Two, to have the ability to reproduce. And then three, to have the freedom to decide when, where, how, and how often they should reproduce. And this will be the basis for most of the talks as we move on. Worldwide, we are quite aware that people living with sickle cell disease have had a benefit to increase their lifespan by using evidence-based interventions. However, we know that sickle cell disease as an entity, the pathophysiology around it, the complications related to sickle cell disease, the treatments that we use have a significant effect on sexual and reproductive health. And I'll give just a brief overview on these three main areas. One would be the prepubertal time, the peri and postpubertal time and early childhood, and also the older adulthood. When you look specifically at the prepubertal aspect in the pediatric population, you have the family who are very concerned about family planning. They have just gotten a child who has had sickle cell. What will they be getting the next time? And subsequently, they'll be thinking ahead about this child's development. Two will be the pubertal development. And this cuts across in very many countries, depending on the socioeconomic status, the availability to specific outcomes. You find that children who have sickle cell disease generally have delayed pubertal development. However, this may not cut across different societies based on the availability of known interventions to improve their outcomes. Thirdly, you would look at the treatments that are being used. And these treatments now depend on when they're introduced, how often, and what are the advantages and disadvantages of these treatments when it comes to future fertility. In the second classification, you look at the peri and postpubertal pediatric and early adult childhood, and we come to the point where, and this will be in two forms, in those affecting the males, those affecting the females, and then across board. You would worry so much about the incidence of sickle-related painful crisis when a girl goes into menstruation, or as a result of priapism, which can lead to erectile dysfunction, or the aspects of sexual health. Will this person living with sickle cell disease be able to have children, participate in growing up with the children, have sexual intercourse, and very many other aspects, because there is this general fear about having sex when it comes to you being someone living with sickle cell disease. Fourthly is the aspect of family planning. So as they grow through this period of transition from adolescence to adulthood, there are different worries that go on. I don't want to get pregnant. What type of contraception will I use? Will I use natural? Will I use artificial? And if I'm to use artificial, what types are safe when it comes to sickle cell disease? When it comes to pregnancies, this is also another worry that does come about when it comes to sexual and reproductive health. There is a misconception that people who have sickle cell disease that are female shouldn't get pregnant, or they can't get pregnant. And these are some things that will be highlighted in the subsequent talks. And then genetic counseling. I have sickle cell disease. Who do I partner with? If I choose someone who also has sickle cell disease, what are my risks of having other children with sickle cell disease? If I marry someone who is a trait, what is my risk? And if I marry someone who doesn't have the gene, what will be the outcomes? In the older people living with sickle cell disease across the lifespan, there are a lot of changes that go alongside the sexual health concerns, maintaining the families, maintaining the marriages, having children, growing up with the children. And as they move across the lifespan, you do find that they go, especially the women, they go into menopausal symptoms. When does this occur? Does it occur according to our normal track lines and other issues? Now, specifically, when you look at some of the complications related to sickle cell disease and how they affect sexual and reproductive health, and I've just highlighted a few which I know we talked about: priapism and erectile dysfunction, menstruation and painful crisis, fertility and use of sickle cell therapies, pregnancy and breastfeeding, and menopause. And more importantly, when it comes to the effects of the sickle cell disease-related therapies, there are a lot of questions that are asked about the use of hydroxyurea and its effect on the reproductive systems, its effect on sperm counts, ovaries, breastfeeding, teratogenicity, and so many others. And when you look at chronic blood transfusions, when can these be used? When can they be used, and what are the benefits, and how do they affect the gonads when it comes to people living with sickle cell disease? I would like to go on and share with you some of the work that we have done within Uganda, looking specifically at the women. And this is a study which was recently done by one of our students, looking at the experience of pregnancy in women living with sickle cell disease in Mulago Hospital. The overall background was that women who have sickle cell disease in Mulago face a lot of challenges when they become pregnant. And they are considered to be women who are at a high risk. And when they are considered as a high risk, they usually want to have special consideration when it comes to care. So this study looked at the experiences that have come about from these women who have been pregnant or either had a pregnancy or delivered within Mulago Hospital. It was a qualitative study looking at about 15 women with sickle cell disease. They were in-depth audio recorded interviews, and they collected data from women aged between 16 to 38 years. And most of the information got was either transcribed and analyzed using a thematic approach. What did we find? We did find that pregnant women with sickle cell disease had both positive and negative individual and health-related care perceptions. Also important to note is that amongst the positives, and when you look at this slide, there are more negatives than positives. But one important thing that came out was the fact that the women wanted the experience of motherhood. They wanted the experience of giving birth to a child free of sickle cell disease. On the flip side, the negative experiences which they reported were having increase or recurrence of painful crisis, the loss of pregnancies. And we will hear in subsequent talks how frequent you do hear about miscarriages when it comes to people with sickle cell disease. Premature delivery as a result of complications, stigma and discouragement. If you are a person who has a first child and you have a pregnancy loss or you have a premature delivery, there's a tendency for the healthcare worker to ask you to, why don't you postpone? Why don't you wait? And this is where the stigma comes on. There's also an issue that comes with your relationship and also the desertion by the spouse. Most people expect that when you get pregnant, you should deliver, you should give birth. And if you keep losing, there's this feeling that I cannot stay with you if you're not able to give birth to a child. On the opposite side, there are also some positive healthcare experiences which were reported in the study. The health workers were dedicated and provided a lot of support. There was the ability to have referral to specialists because of the nature, being someone with sickle cell disease who is pregnant. There was also a lot of support from the male partners who were available. However, on the negative side, there were a few things that could come up: delay in getting medical assistance, informal charges in hospitals depending on where you are, some form of unsatisfactory care. And there was also a big concern that the women with sickle cell disease are not able to deliver normally and would be a group that would undergo cesarean sections more compared to a vaginal delivery. In conclusion, it was found that pregnant women with sickle cell disease lived with a great expectation, however, also had a lot of fear when it came to the disease that would weaken them. Their experiences were generally more negative when it came to individual aspects and also health system aspects. Now, what has SPARCO done and SickleInAfrica when it comes to these aspects? And I just wanted to highlight our SickleInAfrica standards of care, whereby the standard number 2 under health maintenance and preventive therapy does take into consideration the sexual and reproductive health. 2G looks specifically at the genetic and reproductive counseling. 2H looks at the female reproductive health, going through pregnancy, contraception, and fertility. 2I looks at male reproductive health, and 2N looks at transition from adolescence to adulthood. So I'm really happy to say and share with our audience that SickleInAfrica and SPARCO, we do look at this aspect of sexual and reproductive health as key, and we look at it as a way in which we can intervene. In conclusion, I want to share with you what I call the 3 U's in sexual and reproductive health in people with sickle cell disease. 1 is sexual and reproductive health considerations are under-recognized. 2, they're under-treated. 3, they're understudied. And I will highlight this and say they're understudied because it's something where when you look up literature, you have very little or limited information about it. So I do conclude by saying that there is an urgent need to pay special intervention to all aspects when it comes to sexual and reproductive health. And we need to incorporate these services in people living with sickle cell disease across the lifespan. Those are some of my references, which I'll share in the slides. And I'd like to acknowledge the organizers of this World Sickle Cell Day webinar and the whole team. And thank you very much for listening.
Thank you very much, Dr. Manube. Our next speaker is Dr. Lawrence Osei Tutu, fondly known as Dr. OT. Dr. OT is an experienced Ghanaian pediatrician with expertise in clinical pediatric hematology and oncology. He works at the Kamfo Onoki Teaching Hospital in Kumasi, Ghana. My apologies. His research interests include sickle cell disease, healthcare systems, and childhood cancers. He leads a number of advocacy programs on sickle cell disease and is a member of the Sickle in Africa Ethics and Social Issues Working Group. Today, Dr. Oti will take us through an overview of today's topic. Welcome, Dr. Oti.
Right. Thank you very much. And many thanks to Dr. Munube. Fantastic talk with the 3 U's. And it sort of, captures everything that I'm supposed to say. So I'll just represent what he said with photos so that you see exactly what he said. But basically, the ideas are the same. And we look at the angle from how I see it as a typical clinician. And for most of the times when we see one patient sitting in front of you in the consulting room, then you think that it is that individual sitting in front of you, right? But they represent what humanity and community is all about. And this person sitting in front of you is perhaps also thinking about the future, the present, worried and anxious about how they are going to be part of this humanity. And the basic unit for all that we do is a family, right? Whether you're a child growing up from that to a pregnant woman, ensuring that you are going to school and growing old. So it is exciting for me, and at the same time, a little bit of an anxiety as we do this talk, because in Africa, we know that go undiagnosed, and many of them do die still in sub-Saharan Africa. But it's exciting that we are living to the point where we want to have families and talk about our reproductive health. I think Dr. Munube has already touched on what the definition is from WHO, but I just want you to understand that it's simply not about not being sick. And for me, it is also about the mental health aspect of reproductive health. It exerts a lot of mental health stress on us. And one other thing that I also want to stress for me as a clinician is that one of the U's that Dr. Munube described and recognized is sad, because we need to have systems that ensures a continuum of care. And if we are to ensure a good reproductive health for everyone, then everybody must be captured through transition to adulthood, right? And in doing so, we need to have what we call the different disciplines or multidisciplinary team care for our warriors with sickle cell. And you are best to tell me whether you receive this multidisciplinary care where all your experts are available to you without stress and at the time that you need, right? So I just want to go through some questions that people ask, right, usually, and say, how does sickle cell affect my reproductive health? Well, I'll go to the next slide and tell you about sickle cell, the exact mechanism of the disease. And we know that it affects every organ in your body. But as Dr. Munube said, it's the reproductive health aspect was a little bit unrecognized. Yes, he mentioned blood transfusions. There are other treatments now. And the good news about chronic blood transfusions, if you do it right and give very quality blood, is that it has been shown that even those who get chronic blood transfusions tend to have good growth patterns compared to those who do not have, right? So that tells you that treatment has an effect on what we become later in terms of our reproduction. I'll later emphasize on hydroxyurea because it is a standard of care for sickle cell disease now. I've mentioned the psychosocial complications, which to my horror goes unrecognized. I do not remember the last time your doctors asked you, how are you feeling? Do you feel stressed? And so forth. Though that is very important. And I'll specify on hydroxyurea. So your sickle cells, we all know about it. You are all experts than me. So there are certain conditions, then the cells that are nice and beautiful, round and pebble and supposed to be very, very flexible and move through small vessels are not able to do so because of this disease due to one change in the gene that we have. And in doing so, it affects so many organs in our body, right? And gives us several complications. Everybody knows about the strokes, the heart complications, acute chest syndrome, bone pain, and so on and so forth. But very little is said about the young lady who probably who's going through menstruation, how much that is contributing to the pain, her contraceptive choices, will that lead, for example, the choice of contraception unnecessarily expose her to more clot formation and so on and so forth. How is her pregnancy going to be like? Will she get pregnant easily? And will she lose the baby? What are her chances? Sickle cell disease affects even the breastfeeding aspects. I'm a breastfeeding champion. I always love say do exclusive breastfeeding, but imagine being pregnant, having a lot of pain episodes, and receiving pain medications that may delay you starting breastfeeding or will pass through breast milk to your baby and affect the baby. So it is a very complicated thing that we really need to look at. How about the men? The men we know have much more severe complications from the disease itself compared to the women, which leads to a lot of mental health problems such as suicidal tendencies and stroke. But in our culture, men are supposed to be strong, so they don't talk about it and they tend to addiction and so on and so forth for it. And many, many men from priapism are not even able to father children. So the girls usually delayed onset of puberty. Dr. Munube has mentioned the menstruation. I've talked about the contraception and their journey through pregnancy, the childbirth process itself, and the effects on breastfeeding. As I've said, as men are biologically, but from the disease, they cause a lot of low testosterone levels and affect their gonads. So we do know that at baseline, men with sickle cell would have some abnormalities with their sperms and their sperm counts. So there's a lot of anxiety in some communities about hydroxyurea. And I'll show you some publications that says that it is quite safe. Right, so let me go on straight and talk about this particular topic because I'm a fan of hydroxyurea and it is a no-brainer, right? In low and middle income countries, we are to ensure the quality survival of our sickle cell warriors. Hydroxyurea is a simple medication, cheap, available. You swallow it, you don't have to inject it, and it does a lot of wonders in terms of reducing the complications of sickle cell and giving you longer quality life. But there are questions about the potential effect of hydroxyurea on especially sperm count, all right? Because I've said that these are boys or men already have problems with their sperm production and sperm quality from the sickle cell itself. So are we going to worsen that by giving the long-term hydroxyurea therapy? Remember, we want to introduce hydroxyurea before we even experience sickle cell symptoms, right? And complications. What are the implications on long-term, right? So there's several works now, right, that comes out that says that actually, although there seems to be a reduction in the absolute number of the sperms that you have, this reduction is very reversible, right? If you want to get pregnant, the recommendation is simple. You cease taking your hydroxyurea for some time, you get pregnant, the woman through pregnancy will not take hydroxyurea, and the sperm count bounces back when you cease taking the hydroxyurea. So everything is very reversible, right? And it doesn't cause any added abnormalities to the sperm. So it's not very reassuring. But we still say that we are not sure about the effect of hydroxyurea on the unborn baby. So if you want to become pregnant, you stop taking your hydroxyurea for a while, then you get pregnant. If you do get pregnant on it, you suspend hydroxyurea therapy till you finish the pregnancy term, go through your breastfeeding, and then you can resume hydroxyurea therapy. Okay, so that's how it is. So this is another question I usually get in clinic. Do I have a higher risk of pregnancy loss? I'll come to the answer to that. But yes, Dr. Munube did tell you about the complications that we know, right, happens in our women who get pregnant. So it is important that we get the right information to the obstetricians. We work together with the obstetricians and the patient and the family in a family-centered approach to be able able to deal with the complication that we know can happen, especially to the baby as well as the mom, right? So babies can die, there could be early births for prematurity, or baby can be born small, and so on and so forth. So we need to put in place, like Dr. Munobi said, high risk pregnancy interventions to deal with these things. So even in the US, it is known that there's increased risk of stillbirth among pregnant people with sickle cell, and that they have about 26 times they are likely to die. So it is important, and this is the US, right? So it is important to work together to ensure that our women have absolute peace of mind during pregnancy, right? And the last bit I want to touch on is, how can I have a normal baby with my partner who is perhaps straight? Well, it is easy to say that do not avoid this situation, okay? Listen, I do not say ask people to have baby with a particular person or not, all right? I say that we give you information, you make an informed choice, but that choice is up to you. But there are schools of thought that say you shouldn't marry. Marrying is different from having babies. That is my view. But if you are in this position, I mean, it is important for all of us to realize that now there are genetic attempts of making sure that you could have a baby, especially for those who are trained, on two fronts. Be able to test this unborn fetus, whether they have sickle cell or not, and have a baby who is born without a sickle cell, and then also a possible match for bone marrow transplant in the future, okay? So the science has moved on to these areas of what we call pre-implantation genetic testing, okay? So it is possible. But the question is, it is easily available. Is it easily available in us part of the world? So you need to talk to your experts to know what is available. There are so many genetic counseling centers in sub-Saharan Africa, and including Ghana, that are trying to attempt to go into these things. Remember, the future is to have children who have no sickle cell, so that we are able to limit the burden of the disease. So that's where we look at. So I'll end my talk here and thank everybody for listening to me, and acknowledge the organizers of this meeting for inviting me to speak. Thank you very much.
Thank you, Dr. Oti. That was an amazing presentation. We will not waste much time. I'm going to introduce the next speaker, Ms. Ruth Nakanja. She is the founder and executive director of Sickle Cell Association of Uganda. Sickle Cell Association of Uganda was started in July 2000 and has been present representing the interest of persons living with sickle cell disease and their caregivers. Their vision is to realize a sickle cell-free Uganda. Ruth is going to share with us her pregnancy journey while living with the severe condition. Ruth, welcome, my dear.
Thank you. Good evening, good morning, everyone. Good afternoon, wherever you are. My name is Ruth Nankanja Muchibi, as I've been introduced, and I am the founder and executive director, Sickle Cell Association of Uganda. I live with sickle cell disease for the last 49 years. Kindly help me and share my slides, please. Thank you. Yes, I'm a mother. I'm a mother of 3 children. I have 3 babies. I have been married for 20 years. My firstborn is 18 years old. My secondborn is 10 years old, and the youngest is 7 years old. I'm a teacher by profession and an entrepreneur. Next slide, please. Yes, I think what I learned from my personal research on this topic, most of the things that I used as a person, I got from a guide to sickle cell disease by Professor Graham Sargent, and they had done so many studies in maternal and sexual reproductive health. And so even me as a person, I used actually what they had discovered, especially in terms of contraception. Some of the things the science I'm not going to do because the doctors have done, the delayed sexual development, the puberty and all that. I won't go into that detail. But probably for the contraception, because according to Professor Graham Sargent, Depo-Provera is the best for sickle cell patients. And I also used it. That's why you see this space between my firstborn, she's 18, and the secondborn is 10 years. So after my first birth, I began using Depo-Provera for 2 years. But the side effect I got from it is my periods stopped completely for those 2 years. And then I had to leave it because, one, I was putting on too much weight. I was eating too much. And so I felt that I was sort of going to get the hip necrosis because of the weight bearing. So I had to discontinue after 2 years of use. However, even after 2 years, I never regained my periods. So a whole year passed without getting periods. And in the process, before getting back my periods, I conceived, and I didn't know I had conceived. So I lost that one eventually. I think that was sort of crossing to the 4th year because I didn't know I had conceived. And I just took some antibiotics. I think it was ciprofloxacin that I took during the pregnancy. So I had to lose that fetus at about 2 months. So then I regained my periods. So I started fearing. I started fearing using contraception again. So I started using the natural birth control. And when I had my 3rd baby, I did a TL. Can I have the next slide, please? Yes, like what doctor has said, I think there is very limited data, especially in Uganda, about sexual reproductive health and issues of pregnancy. But there is very limited data as well in terms of fertility and sickle cell disease, but time between initial sexual exposure and initial pregnancy suggests that fertility for child is close to normal. However, most patients are under denial and many myths associated with sickle cell disease. So therefore, they are not sexually active. The families will tell them you don't have to give birth, you can't relate. And so that one disturbs them. And so they prefer not actually involving themselves. Can I have the next slide, please? Yeah, so effects of pregnancy on child with sickle cell disease and mother. There is greater risk, of course, of acute chest syndrome and painful crises, especially in the 3rd trimester and early postpartum, and greater risk of preeclampsia and maternal death. Effects of contraception are theoretical, but effects of pregnancy can be fatal, depending on, first of all, you as an individual, where are you getting the care? And what about your spouse? Is he there to support you? That also, I think, counts. May I have the next slide, please? Yeah, and then the effects of a child on SS mother. What I learned, greater risk of fetal loss at every stage of pregnancy, then the growth retardation. Sometimes you can have a low birth weight baby, and then sometimes you can have a stillbirth. Babies are born dead. Next slide, please. Yes, so management of SS pregnant mothers, my experience and recommendations. Patients should know the significance of genotype testing of the partner. For example, actually, me, when I was getting married, during that time of courtship, I never had this time of let's go to the beach, let's go have fun, let's go have a drink. All our time, the first 2 years of courtship, I would take Mr. Muchivi to the sickle cell clinic, educate him, and ask him, show him the risks. If you're going in for me, this is what you expect. One day I'm going to break down. You have to carry me. You have to feed me. You have to bathe me. So are you going to live like a woman who doesn't have sickle cell disease, then settle with me? And he would say yes, but I wouldn't believe that the yes was actually yes. And then we had to go to that level of testing him. He had refused because he was like, yeah, I know you have sickle cell disease, but then why should I then test? I told him, no, I'm a counselor. I can't just go into a blindfolded relationship. But in me, I had two decisions. If I found him that he had the sickle cell trait, then I was just going to adopt children. But fortunately, I found out that he was AA and I was SS, so which was okay. So this is very important to patients. Open up to someone early enough. It's better to leave you in that initial process or relationship other than someone stressing you till death. So then attend ANC more than the 4 times that the Ministry of Health recommends, because you need close monitoring. And then give iron and folic acid supplementation during pregnancy, monitor the fetal and consider operative delivery if evidence is fetal distress. Transfusion protects the mother from acute chest syndrome and painful crises, but no evidence of fetal benefit. Next slide, please. Yes, so my experience as a warrior mother, personally, my 3 pregnancies were very smooth with no blood transfusion or painful crises. I used to attend antenatal at 2 months of pregnancy. I used to do 2 clinics concurrently, that is the sickle cell clinic in Mulago and a specialized gyne doctor through the 9 months. All my 3 deliveries were cesarean section. At 5 months, I would start taking 5 types of supplements. Next slide, please. Okay. Yeah, so the first one, the supplements that I used to take, I would take Stress Active. This was to prevent the stress and anxiety. Of course, we all know that stress triggers the painful crises. It can even go into the acute chest. So I would prevent that by taking Stress Active supplements. I would take immune boosters to boost my immunity. I would take royal jelly for good appetite, so I would eat everything. Then calcium. This was always taken in the last trimester to prevent the expected painful crises. Then I would take Pregnavite for pregnant mothers. So I used to take these 5 tins diligently every month for the last 5 months of my pregnancy. Next slide, please. Yes, so in conclusion, let us bring sickle cell disease to light if we are to get rid of it and save the future generation. I believe we need to start encouraging people to open up to their spouses and do genetic screening before they have children. We need to support them to do both clinics. And to the health workers, I believe we need to do more in terms of research so that we have these facts right, so we can make informed decisions. Thank you very much. And thank you everybody for putting this together.
Thank you, Ms. Ruth Nakanja, for that insightful presentation. I really learned a lot. Now I'm going to hand over moderation to Dr. Oti Dr. Oti.
Right. I think, thank you very much. Our next speaker is Mr. Carlton Zulu, who is a sickle cell warrior himself. He's living and surviving in sickle cell anemia. He's 33 years old, and he will speak on his sexual experience and reproductive health choices so far. Mr. Zulu.
Hello, guys. How are you? Good evening
Good.
to everyone.
Welcome.
All right. Can you hear me? Just checking my network if it's all right.
Loud and clear, sir.
Loud and clear. Thank you very much. All right. My name is Carlton Zulu. I'm a sickle cell patient, and I have sickle cell anemia that I was diagnosed when I was 2 years old. And I was born from a family of 4. My father is a Zulu. He is South African. He married a Mozambican. And I was born and raised in Zimbabwe. So generally, I would say I inherited the sickness, I think, from my mother's side. When the family, we went through the genes, trying to figure out what was happening to me. So let me just find somewhere where I can sit and finish. All right. So I was born with sickle cell anemia, SC, and I'm a patient. I reside here in Cape Town, South Africa. And my sickness had it through childhood, and I would say, breaking down quickly, as a sickle cell patient, going through the sexual reproductive system and trying to survive in adulthood. And it was quite a rocky road. It was quite a hectic journey, because also growing up in Africa, I would say partly in Africa, and living and surviving with sickle cell is one of the hardest struggles that people living with sickle cell are facing. So I remember when I was growing up, even trying to mingle with people, friends and family, it was more of emotional, mentally, and it affected me very bad, even in my academics, because whenever I would feel like I'm a little bit strong, the sickle cell crisis would just hit. Whenever I would feel like I want to go and do my exams, or I'm preparing for my exams, somehow the crisis came from nowhere. And yeah, it was a very, very painful process. So I would say, yeah, I went through with my doctors at the dermatology. They explained to me that it was pre-spasm, where persistent and unwanted erection of the reproductive organ. It also affected me also. I would say it affected me very well, because when I wanted to date, like a normal person, I was in some complications where even my spouse that I was going out with by that time, they wouldn't even understand what was happening to me. And the stigma, it really affected me, especially living with sickle cell anemia. So there were moments where I would hide, I would shy away from my sickness. And even from family, there was a time when family couldn't even understand. When you're born in Africa as well, and you might grow in a place where people are uneducated about the sickness, they don't even know what's happening. And most people would say things that will get in your ears, or you hear things that you're not supposed to be hearing, especially when you're in a crisis. Some family members, I would say, they would think maybe it's witchcraft, and then you start going on the wrong path of life, where they're trying to look for a positive cure or trying to look for help, and then they'll be taking you in different directions, whereby at the end of the day, you end up being kind of lost. So I would say men with sickle cell, as I am a man, I think, because I can't speak also for women, because women also, they go through their own, they go through their own difficulties as well. But as a man and as a young man who was growing in Africa, I tried to adjust. I tried to live a normal life with other kids, but it really affected me in the community and even on the academics. So fortunately, my father managed to move me back to South Africa, where I got some proper care, good medical health, and the people who were around me by that time when I moved here in South Africa. It was, I think, 12 years ago. I was still young though. They really helped me, and fortunately, I managed to see good doctors from the hematology side here in Cape Town. With the there are a couple of doctors I can even mention. There was Dr. Yubei. There are certain doctors that they helped me get through what I'm going through, and accepting that the sickness and the disease, it is not the end of the road, but they are also trying to see and help us manage this kind of sickness. So as I was growing towards my adolescence, as I was starting to see and realize that this is the moment where I need to start going to work, it also affected me a lot, I would say, because whenever I wanted to do my level best at work as well, there are certain things that I endured, like you end up losing your job, and at the end of the day, you really need that job. You really need to stand. You really need to support other siblings. You really need to support other family members or your kids and stuff. So it was a kind of a rocky road that led me to start wanting to know more about what
I think we may have lost Mr. Zulu there, but I think we got the gist of what he's saying. We'll try our best to keep within time and have enough time for the Q&A. So Miss Lucy Nyongani is next, and she is 46 years old. She lives with sickle cell disease. She's from the DRC, but also has been living in South Africa for 20 years. She will talk about her experience with menopause at age 33.
Hello, guys. I want to start talking. I don't know. My name is Lucy Nyongani, as you know me, and I've been diagnosed with sickle cell disease at the age of 6 months in DRC Congo. And I'm a 46 years old lady. I've got 2 children. I had my first born when I was 22, my second born when I was 24. I did struggle with having cysts. Cysts, you may imagine where it was on my ovaries. The first cyst I've ever had was in Petersburg, and it was a cyst that was a bit bigger than a tennis ball. And because it was bigger than the tennis ball, they actually took that cyst out of me, and they did an examination over it to find out how that, do I have cancer? Is it cancerous or not? But praise God, it wasn't cancerous. They gave me the wrong blood at that time. And then my blood started now reacting toward this new blood that they gave me that was completely wrong. So my blood dropped down to 4 HB, and I actually got a clot, not a clot, but how do you call it? A stroke. I got a stroke because of my low blood count. And after they removed that first cyst, I kept receiving more cysts all the time. But when we came back to Pretoria, I had another feeling of the cyst again. It's like a stabbing pain. It's very pungent pain in your tummy, in your stomach. You just feel it. It makes you feel very uncomfortable. And we went to see a gynecologist here in Ferry Glen Hospital. And that lady, she was like a man. She looked like a man, and she was talking to us like a guy can speak to another guy. So she actually told me, she says, you know, you have a mass or you have a lump in your stomach, and in about 6 months, you will come calling to me for me to operate. We were shocked by her response towards us. Myself and my husband, we were very shocked. We looked at each other and we looked at her. Say, yeah, that's all that I have to tell you. You'll come back to me and I'll operate on. And I said, no way. You will never touch me at all. And in the course of the week, but the following Sunday, I was at church, but I was immersed in my thoughts. My thoughts was just disturbing me about this issue that I have, this mass that I have. I didn't know, is it a muscle? What is it? Can something else go inside of you just like that? And I saw a lady that came to me and said, Lucy, I can see you are here, but I'm not sure if you are really here because you are lost in your thoughts. And I told her, yes, I'm thinking of this and this because of this gynecologist that I went to see. No, she gave me a doctor's name and number, which I contacted. But unfortunately, that doctor was fully booked. And then they told me, they said, no, but there's a new doctor here. Would you mind seeing her? She's a good doctor and everything. I said, okay, it's fine. Let me go to her. And that doctor's name was Dr. Clenance here in Pretoria East Hospital. She actually examined me. She sees everything. She kept me calm, and she actually made me and my husband feel kind of at peace with the situation because I used to receive those severe pain most of the time during each and every single month. I think just before you get your period, I used to have those severe pain. And then she didn't tell me that she will operate me in about 6 months or so, but it actually came out true that after 6 months, she actually went with me into surgery. And when she opened me up, she found out my tube was so swollen. My ovary had about 4 cysts. And because it has 4 cysts, it lost its balance and went and got stuck to to the appendicitis. So she just cut the end of the tube. So that was the mass. In fact, that was the mass that the other doctor saw. But she told me later, she says, no, I saw that there was a mass, but I didn't want to tell you that there was a mass because you were already freaking out from the other doctor. So the only thing she told me was that you have 4 cysts on your ovary. And then after that, that was when I was 28 years old, that they removed half of my ovary and they left me with the other one. That ovary actually worked for 9 months. I was having my period for 9 months. And then all of a sudden, one day, it stopped. I was like, uh-oh, am I pregnant or what is happening now? I need to really find out if I am pregnant. I went to see the gynecologist. The gynecologist tells me, no, but you can't fall pregnant if you have cysts. The other ovary also, after 2 months, 2 months after that big operation that I've had of them removing everything, not everything, half of my ovary. 2 months later, I developed 4 cysts on the other ovary. So I went to see the gynecologist. She looked at me. She was very petrified. She looked at me. Would you like to go through another surgery? I said, no, not now. Not now. And I resisted like that for 5 years. So 5 years, so I was 33 years old when now I was now faced with a complete hysterectomy. I just asked the doctor, I said, okay, since you are going to remove this ovary, because that ovary had 4 cysts, it lost its balance, it went and lay down on the urinary tract. So my kidneys were in distress. They were moving up and down all the time whenever you go wee. So that surgery, she did it together with a urologist together. They did it together, and it was a successful surgery. But as soon as they finished with me in the surgery, they put me straight into ICU for 2 days. And then one day I spent in a normal ward, and then the rest of the 9 other days I've spent in an enclosed ward where you are all by yourself, and you and the TV, and there's the bathroom there for you. So as many people know, Ward 20 is, it's not a good ward because you are isolated. So after that, that's when now I'm noticing that my mood started swinging up and down because they remove. So I told the doctor, since you are going to remove my ovary, remove also my womb, because I do not want to start suffering from fibroid as well because of the many cysts that I've been having. And after that, they did all of that. They removed everything. So after they've removed everything, it was now my mood that was swinging. I can be happy now, and then all of a sudden I'm crying, or all of a sudden you feel sad. You just don't know what is going on with you. And then there was the hot flashes. Hot flashes I could feel it. It's start from here and up, but I used to sweat, not on my face, but it was on my back. And that I was feeling it whenever I drive. Whenever I used to drive my children, specifically during summertime, when you're driving, when you come out of the car, you feel your back is like sweating. It's like you are weight. And I even remember one time my little girl, my daughter's children, the girlfriend came to hug me, and then they looked at me with a very weird look, saying, what's going on with this woman? And I couldn't explain to them what has happened to me.
Yeah,
So,
Mrs. Imani, we have one last talk and Q&A. May I ask that you can wrap up in about a minute for us?
okay, no, that's fine. I'm finishing soon. And it also, I found that my vagina was getting dry and to have sex was painful. And I went to see the gynecologist. The gynecologist prescribed me some gel. And, but the most thing that I'm finding out with sexual intercourse is whenever you enjoy, you have back pain or chest pain or hips pain. So my husband sometimes tells me, but I can't continue giving you these pains. We need to start abstaining ourselves. That's all I had to say. Thank you.
Right. Thank you so very much. I realized my mic was off when I introducing you. So Mrs. Lucy Nyugani, Miss Lucy Nyugani, 46 years, as you heard, has had menopause at the age of 33. And she shared the experience with that. Thank you so very much. So we now move on to Sharifu Tusubira, who is a PhD candidate at the University of Kansas, focusing on quantitative genetics. And for over 10 years, Sharifu has been promoting sickle cell awareness and advocacy in Uganda. He was the first executive director of the Uganda Sickle Cell Rescue Foundation and is a board member at the Uriel EON Sickle Cell Disease Association of the Midwest. So in this webinar, Sharifu will speak about his experience with priapism and reproductive health. Sharifu, if you could do that for us briefly, and then we'll move on to the Q&A.
Thank you so much. I think in the interest of time, I'm going to cut short what I was going to say, because I think the Q&A is supposed to start at 11, and I mean by 7 minutes already. To me, I think one of the key things I wanted to first of all touch base is that as a person living with sickle cell, one, we need to understand there's a lot of mental health issues. The first mental health issues often come during the time of the mate selection, the time when when it comes to mate selection, we want to find the partners and mates. However, it's hard because of all the social stigmas around us, and sometimes the lack of support system. We don't have people to talk to, people who may be there for us. Looking at my own experience as a person living in sickle cell, I had a lady I was interested in marrying, and she actually told me very point blank that I cannot do it because of your sickle cell. And that to me was a very depressing time, and I felt very low and had dealt with a lot of mental health at the time. But however, how did I cope? I did reach out with a few friends. I think Ashraf, one of the folks on the call here, was able to get in touch with me and support me throughout the time. So I do believe that having to address the mental health issue is one of the key issues that we need to deal with. In addition with the mental health, another issue I think is the priapism. Priapism has been talked about already, but I think my case with priapism, I had chronic priapism. This is where, I mean, almost every night and every day you do wake up in pain. So it becomes a very hard thing to deal with, because one, there's first of all, the social stigma around priapism. You can call your family member and say, hey, my hand is hurting or my back is hurting, but you not call them and say my penis is hurting. So that's one of the key issues there in terms of dealing with the social stigma that do surround priapism. So I do believe that for healthcare workers, we must be able to add to have screening questions that do talk about sexual and reproductive health. Because when you come to your offices, you do ask how are we feeling, do we have any fever, do we have any chest pain and what, but I think you don't ask anything to do with priapism. So I think that's one of the key things that healthcare providers should be able to do. Among the other things that also was also key for me to talk about, I think, but we did talk about long-term the short and long-term effect of the therapies. Hydroxyurea is one of the things that was talked about before, but I think there's also an issue of opioids, because opioids are what, especially where I am in the US right now, and often our pain is managed by giving us opioids. So opioids have some short and long-term effects. For men, we have to deal with the testosterone issue that deal with long-term use. So those are some of the things that I think healthcare workers should be able to talk about, or even the general sensitization of people living sickle cell to know that, you know what, if you're going to take these opioids for more than 10 or 15 years, you must be able to deal with you must be aware of some of the challenges that you will most likely be able to face. And I think one of the key issues, to wrap it up, is as we do talk about all the things that have been highlighted, I do think that the awareness of the sexual and reproductive health that do affect men have not been that do affect men are not necessarily getting the time, they're not necessarily getting the attention that they deserve. Because one of the key things is we do talk about priapism, but we don't talk about the erectile dysfunction that may happen as a result of you having priapism. We also do not talk about the sperm abnormalities enough. I mean, I think Dr. Manube did talk about that, but ideally, the general population, so many men may not be aware that having sickle cell alone would have some of those things that would be affecting you. I think the other key issue also would be the hypergonadism, one of the key issues that would affect the poor libido, poor poor testosterone as well. But I think those are the key issues to me that I think would need to be talked about, and also make sure that the general population is well aware of, because we are very much aware of all other effects of sickle cell, strokes, and some other things. But when it comes to the health and reproductive issues, we are not getting that much awareness. We don't know what's going to happen to us because we have sickle cell. So to me, I think those are some of the key issues that need to be talked about, especially for people who are living with sickle cell. And I'm glad that we had a webinar like this to be able to talk about some of these things. But I think it's still very, very essential and important for you as healthcare providers to talk about these things for people who come to see you, so that they know that, because often you would be able to say that you have a risk of stroke, but you may not say the risk of priapism, you may not talk about the risk of poor libido, all those other risks that would come as a result of sickle cell. So I think, to me, those are some of the key issues that I would like to highlight. And in the interest of time, I'll probably just stop there, so that we can be able to do the Q&A, so that we can finish on time. Yeah.
Awesome, Sharif. I think you laid it well. I think men are suffering in silence, and we need to come to the table and deal with it, right? So we move on to the Q&A, and I think Molin will help us read their questions, and we try as much as possible to answer them. Thank you.
Thank you, Doctor. I am looking for the questions and I cannot seem to find them. If you can go through them, Doctor, for us.
All right, so I've opened the Q&A box in front of me now. The question says, how does sickle cell affect the male and female reproductive systems? Furthermore, from this, what risks or consideration that people living with sickle cell should be aware of when family planning? Maybe I mentioned it during my talk, and Dr. Munobe Sharif himself has said that even males have more effects in terms of the disease itself affecting their gonads, so their testes, and their ability to produce testosterone. We know across both male and female, they have delayed puberty and delayed onset of puberty, and we know the issues that many speakers have alluded to with menstruation and pregnancy. So that has been the main issues of the talk. In terms of family planning, it is my issue. You need to discuss choices very well with the family planning providers. What stands out is that you need to be careful and not go in for choices that increases your risk of forming abnormal blood clots that we call DVT, or deep venous thromboembolism. And I think one of the speakers said Depo-Provera, for instance, worked well for her. And that's a progesterone-only contraceptive, and the other methods like barrier methods as well. So, I mean, this has to be discussed very well so that you know the side effects of the various choices and what to choose. I'll end here. I don't know if Dr. Munobe has anything to add.
Thank you, Dr. Oti. Just to highlight the importance, and I think I tried to highlight that as SickleInAfrica and Sparkle, we have deliberately separated the male reproductive aspects and the female reproductive aspects such that we're able to look into this. As Sharif mentioned, when you go for a consult review by a specialist, if you are not complaining about something specific at that time, it could easily be missed out. And if you don't ask those, he called them reproductive health questions, you would actually miss a priapism, or you would miss a miscarriage, or you would miss a first sexual debut, which could have caused this person to come in with a crisis. So some of those questions are very, very important when it comes to reproductive health. And I must say that the options for family planning in our setting are really based on the knowledge provided to the healthcare worker and the area in which they are providing. Thank you. Over to you, Dr. Oti.
All right. So from Julian, Julian says, thank you. Does pregnancy increase the risk of ischemic stroke in sickle cell anemia? Dr. Munubi, your thoughts?
Very interesting question, because as you get pregnant, the hypercoagulability does increase. We don't see it unless there maybe have been a previous history of estrogen use. But otherwise, from my experience, there is no additional risk. Thank you.
Yeah, I mean, theoretically, it is, isn't it? So some providers speak of aspirin and all the rest. So, yeah, I mean, we need to talk about it in that individual way specifically. It can cut across everyone. That is why it is important that we ensure continuum of work, all right? And everybody is around one table for that particular patient. We really need to work at that approach. Solange Mela, how do you engage with your partner when discussing these risks and topics? Is there educational tools or support organization that can help with this process? Dr. Munubi, do you have any tools?
Yes, again, Solange, very important question. And I think that these are some of the things I mentioned with my 3 U's: understudied, undertalked, underrelated. A toolkit for some of the aspects that she is talking about is very key. And I know in very many centers, we tend to have educational tools for the acute complications and a few chronic complications. As we move across the lifespan, and with the interests that are being shown by the SickleInAfrica Consortium, I know more and more of these tools will be developed. Thank you.
Awesome. So Solange also has a question about the message and advice. I think Dr. Munubi has touched on that. So for the interest of time, the next question says, I am 29 years old, but on hydroxyurea. Woohoo! Congratulations. That's exactly what we want everybody to be on. Will I be able to get pregnant, and how is it possible? I'll take this one. I mean, hydroxyurea does not stop you from getting pregnant. It does not make you infertile or reduce your chances. But remember, getting pregnant has other contributing factors. Most importantly, you must find a partner who is also able to conceive, right? So if we control for all other factors and it's left with only hydroxyurea, then it has no extra bad effect on limiting your chances of getting pregnant. However, what we have said is that because it potentially can affect the unborn baby because of the nature of the drug, we advise that whilst you're on it, do not get pregnant. And if you want to get pregnant, you go off it, then you get pregnant, finish your pregnancy and breastfeeding, then you can restart. If you do get pregnant while on it, no problem. You just stop taking the medicine and you continue your pregnancy. The protection to prevent pregnancy is for both female and male, right? Because we also know that it can affect the nature of the sperm. So that's what I said about hydroxyurea. So it says, have there been any recorded fetal deformities in birth by women who took hydroxyurea while trying to conceive and while pregnant? What options are there for women to manage their health while pregnant if they cannot take hydroxyurea? So in the big clinical trial called the MESH trial that, ushered hydroxyurea therapy onto the standard of care of sickle cell disease, some women got pregnant while taking the medication and opted to continue with the pregnancy. Till date, nothing has been recorded in terms of fetal abnormalities. The caution is because we know that it can do that potentially even in animal models. So we try to prevent it. But in real world, there hasn't been any records yet. No, so it's quite safe. What options are there for women to manage their while pregnant? So there are already, as Dr. Munubi described, standards of care for women who are pregnant. Are women or warriors with sickle cell who get pregnant. They get managed as high-risk patients, right? and so have some cautions that they go through. We've had a real world experience of somebody who got pregnant, taking vitamin D supplements, and others being seen more often at ANC, and both mother and baby being monitored. Blood transfusions are important, and then they help you have a good pregnancy. All right. So even if you are off hydroxyurea, yes, your medical care team, which is not only the hematologist, but the obstetrician and the baby fetal expert, will come together to manage you. Dr. Munube, any thoughts?
Thank you, Dr. Oti. I think you have highlighted the importance of attending to a multidisciplinary approach. If you are to avoid any complications related to pregnancy, you will need to have a full team together who will help this mother who comes in. An individual approach to care is very key to ensure that no complications do occur. Thank you. Over to you, Dr. Oti.
All right, Dr. Bonobe. Says this is Caesar. Says, how can men and teenage boys manage priapism? What are the long-term complications of priapism? Does it affect male fertility? Dr. Bonobe, maybe you need to stress on what Sharif said about priapism for Caesar.
Also, Caesar, thank you for the question. How can men and teenage boys manage priapism? And I think it was highlighted that priapism is a common occurrence which does affect most men and boys with sickle cell disease. And he said 1 in 3 if you looked at the statistics. We are also seeing an earlier occurrence of priapism. I do recall a boy as young as 4 years with having a priapism. And what basically this means is that the earlier onset of priapism leads to a long-term complications, the erectile dysfunction. Management is really based on the extent of the priapism, whether it is stuttering, whether it is recurrent, and the need for the clinician to intervene. Initially, rehydration, pain medication, and relaxation has worked well. When you have stuttering or recurring priapism, then in some cases, surgical interventions have to be used. There are a few drugs, hormonal drugs, which have been used to prevent the priapism from occurring, but they do have a few side effects, breast development, a few features where these boys tend to get a little bit feminine, and also the challenges with regards to surgical operations, which can lead to erectile dysfunction. Thank you.
Right. I'll just add that just recently, there's a clinical trial called the Spartan trial, where they are trialing a medication called crizanlizumab. Some of you may have actually used it at Darkview, and it has shown great promise, right, in preventing recurrence of priapism. So probably very soon, fingers crossed, crizanlizumab can be taken in addition to hydroxyurea for especially those who may have genetic risk of priapism. That's a fantastic question. Okay, so interesting presentations. Thank you. I saw you mention taking iron and folic acid supplement throughout the pregnancy. Many doctors do not consider this, especially for the iron in excess. How can this be reconciled given our risk for iron overload? Very interesting question, Dr. Bonobe.
Yes, so pregnancy does require an increased demand for iron. And this is where, whether you have sickle cell or you don't have, your obstetrician and gynecologist will definitely include that. The teaching has been that since you have a recurrent breakdown of your red cells, the iron stores within the body should be sufficient. But because of the physiology around pregnancy, the iron supplementation is very important, and this does not increase the risk of iron overload. Thank you, Ari, for the question.
Yes, absolutely. So every patient needs it. So sometimes we think that a sickle cell patient does not need, but a sickle cell patient do need supplement at times, especially in sub-Saharan Africa, even for growing kids. Okay. So it's all about giving, monitoring to make sure that it doesn't happen. Okay. All right. Good evening. I request Dr. Lawrence to enlighten me on the possibility of genetic screening of conceptus, for sickle cell anemia as a way of birthing a child free of sickle cell anemia. Well, so that's what I mentioned, that there's this PGT or genetic testing that happens. It's on two fronts, actually. So that is happening in higher centers. I know I saw a paper where in Nigeria, they have been used as well. It is used in addition with what we call in vitro fertilization. So basically, they select how do I describe, like unformed babies, like test tube babies as we describe it, test it to make sure they don't have the sickle cell gene, and then implant it into the womb of the mother. So it is now being done. They are depending on the ethical considerations of your country and your organization, but you need a lot of genetic testing for that, genetic counseling, and most centers from Uganda, Ghana, and the rest provide all these. We need to be stronger as groups, in terms of advocacy groups of warriors, to be able to understand these things and look into them more and form close partnerships with our caregivers, being the experts, so that there are more information put out there for people to, especially those who are able to have the means to take advantage of this. So it is there, it is now in the space, but it's important for us to know about it. Right. Ruth and Lucy, thank you for sharing your personal experience. That's so powerful. This is from Regina. Lucy, can you see the questions now? You want to continue?
I just wanted to I wanted to give advice to young people who want to get married or want to know how do they match together.
Yes.
I would prefer to, for me, what has helped me was my pastor. I had a pastor who told me, say, have you spoken to your future husband about your sickness? I was like, no, I've never. I said, no. He told me, he says, no, you need to tell him that you have the disease. And otherwise, once you go into the marriage, you will now start fighting because he doesn't know what he's putting himself in. So he needs to know before you even get in love with him, before you even start loving this guy, tell him already. So that really helped me to do that. I told my husband now, before I even told him, yes, I do, we can now start working together, I made sure to tell him that I have sickle cell. And he told me that he is a. So that is how I can maybe advise people to get themselves a blood screening test just before they go into the marriage, because that will prevent more sickle baby being born. Yeah.
Right. Thank you so very much, Lucy. So there's so many questions, a lot of them on hydroxyurea and priapism, which we have touched on. So I hope you have your answers from there. And the genetic screening as well, I've tried to explain as best as possible. These things are best done in person as well. This one is also on priapism. And Festus Ogada says that toxicity of hydroxyurea in long-term administration affects the physiological health of the user and lead to early mortality. No, it does not lead to early mortality. Actually, it prolongs survival and quality of life. So you need it if you have sickle cell anemia. What is the experience of using hydroxyurea among sickle cell warriors who has used for quite some time now, or someone who has treated patient for quite some time now? I don't know if any of the speakers have used hydroxyurea that can speak to.
I can speak about it. It actually improves your lifestyle a bit. It changes the frequency of you having pain at the beginning, once you start taking it. But the long term, I don't think it's really active as it should. Maybe they need to head up again. I'm seeing my doctor tomorrow, but because I've been having pain here and there. But it is helpful. For the first 10 years of my life, I actually managed to put on or to gain some weight with taking hydroxyurea. But for the moment, I'm struggling a little bit here and there because I have pain today, and then tomorrow you don't have a pain, and you kind of skip a day without pain, and then the following day you have a pain. So it's like that. So I need to see the doctor tomorrow and find out for me.
All right, thank you so much for your personal experience. And exactly so. I mean, the needs, the body's needs, physiological needs also changes. So sometimes we need to up our dose of hydroxyurea. That's what called the dose escalating. So you need to, you are seeing your doctor. So they'll look at several factors. And yes, sometimes it sort of reaches its maximum peak where you do not gain any more benefits. And luckily, we have so many other disease-modifying agents now. I mentioned crizanlizumab, Adagvio. There are so many other things that you can add to hydroxyurea. You do not need to be in pain, actually. So those of you in very well-resourced centers, you are blessed. We are still trying to get some of these agents into some of our countries. I think it's 1:30 p.m.
Dr. Oti,
sorry. You can go on, please.
Yes, so I just wanted to quickly, there's a question, I don't know if we responded to it, about the gene predisposing to priapism. I mean, there have been some studies that have looked at factors, I would say, that are associated. So first and foremost, the older age, the severity of the sickle cell genotype, HBSS versus SC versus etc., and also the association with pulmonary hypertension and those who have previously had a vascular necrosis. There is one candidate gene, because I do a bit of genetic work, the gene transforming growth factor beta receptor 3 has been associated with priapism, but in South America. So this is a gene that we could possibly test in our own population. Thank you, and over to you, Dr. Oti.
All right. I think Ruth wanted some comments, and we'll take comments from speakers and maybe round up.
Yes, Doc. For like countries where you haven't got hydroxyurea yet, I can give you an experience of myself. Me, I've never taken hydroxyurea, but sometimes I take 10 years, 15 years, without getting one painful crisis. But even when I get it, it's mild, simply because I drink right. I take 5 liters of fluids every day, eat the fresh fresh fruits and vegetables. I prevent malaria. I don't stress myself. I try as much as possible. Anxiety, I lower it down. Definitely, I do my bloods every 3 months just to check if there's anything coming in. I do malaria prophylaxis plus a mosquito net. And then I eat right, even when I don't want to eat, because normally our appetite is down. I sometimes have to close my eyes ever since I gave birth just to eat, just to make sure I've not missed a meal. So, and then like we have been discussing that sickle cell has issues of mental health. Actually, personally, I normally say it's more of a mindset disease than a medical problem. So if you feel that I'm sick, in most cases, you'll always be sick. And if you think that, no, I'm a normal person, apart from that time where the crisis has hit hard, you'll always be fine. So as sickle cell patients out there, you need to build your self-esteem. And when you have a high self-esteem, even if someone leaves you during courtship, you will move on, because one day you'll find someone who loves you the way you are. Thank you very much for everyone who has made this possible. Thank you, SickleInAfrica. Thank you for the sponsors. Thank you for the researchers. Bye.
Right, Maureen, over to you.
Thank you very much, everybody. Before I close with the closing remarks, Cesar, you said you had something to say about hydroxyurea. I'm giving you a minute.
Who, me?
Cesar, yes.
Oh, okay.
Hello? Hello?
Cesar is muted.
Okay, then. Looks like Cesar is muted. I'd like to thank all the speakers. I'd like to thank all the speakers for the very insightful presentations and our resource persons for the question and answers. Many thanks to the SickleInAfrica Data Coordinating Center, SADC, and the different support groups for organizing, and to Wilson and Chandre for the technical and logistical support. Thank you all for attending, and we look forward to seeing you again soon in our forthcoming webinars.
Marlene, sorry, I've finally unmuted. Can I talk quickly?
All right, 1 minute, Cesar.
Thank you. I just wanted to talk about Hydrea quickly. For me, it helped me get my health to the point where I could have my twins. It really helped. I went from having an HB below 7 all the time to having my HB above 10. It helped me have my twins with very few crises. I was quite healthy. I went against the grain and I actually stayed on Hydrea throughout my whole pregnancy because we figured I'd been so sick without it. And I needed to be healthy for my twins and I to survive the pregnancy. And it really did help, but it helped with a good diet. I can't say I would be alive right now if I had not. Yeah, that's it.
Thank you very much. Molin, so sorry. I just saw a message from Chandre who says there's a feedback link that we want people to complete. So people should please look at the link. Chandra, is it in the Q&A chat or is it in the chat box? People should please complete it so that for our next, it's in the chat box. For our next sessions, we can know what to do. Thank you so very much. Oh, thanks for the positive thing about hydroxyurea. Quickly, somebody wanted to know if there's a criteria to start hydroxyurea. The only criteria is you have sickle cell. Start hydroxyurea. Thank you.
Thank you so much, everyone. Have a good night.
Thank you. Bye.
All right. Thank you. Bye.
Bye.
Thank you, Lucy.
Bye. Oh, you're welcome. Bye-bye.
Thanks, everyone. Bye-bye.
Yeah. And the one in Kalenga, all the